I am a pain psychologist, and I am housed in Virginia Mason across the street from you guys, but I actually reside in Scottsdale, Arizona. So that's why we're doing this over Zoom. But I do see the majority of my patients live in Washington State, but they're kind of spread out all over. And I do see some patients in other states as well, because I'm licensed in about 40 states. And so I do all of my services virtually, which works out really well for patients, especially those dealing with chronic pain, because it can be hard to get yourself to an in-person appointment. So the virtual visits really allow me to come to you in the comfort of your own space. So I run group classes for patients, and I also see patients individually. And so what I'm going to walk you through today are essentially just kind of the nuts and bolts of what pain psychology can offer. I think, this field has been around for quite some time, but it's starting to gain some traction, and people are really starting to understand the importance of the role of pain psychology in treating chronic pain. It used to sort of be an afterthought, like when all the medications and treatments don't work, go see the shrink. But now, thankfully, providers are really catching on that pain psychology is best used early on in one's pain journey to help in preventing that pain from becoming chronic, but also to get people out of chronic pain. And that's thanks to what we've learned about the neuroscience of pain. So a lot of what I do as a pain psychologist, and what you would do whether you see me or another pain psychologist, they always start with education about the neuroscience of pain. And when a patient is referred to me, they actually start by taking my group class series, which I deliver just like this via Zoom. We sometimes have tech issues, but not usually. And we go through educational materials around pain. I think that knowledge is power. And the more that you know about what is going on in your body when you're experiencing pain, the better the decisions you can make about your care going forward. And so it's really about empowering patients to realize that you have a lot more control than you might give yourself credit for, and that there is a way out of pain. So we always start by defining what pain is. And anybody who's seen me, a pain psychologist, probably has experienced pain before, and they often are having it in that moment, and they know that it's an incredibly unpleasant sensation, but a lot of times we don't stop to think, why do we have it? What is the point of this pain thing? Well, I'm here to tell you that ultimately it is a survival mechanism, and it is our best survival mechanism. It keeps us safe. Our nervous system is wired to warn us when there is harm going on to the tissues in our body, or the potential for harm going on, and so that we can change our behavior. That pain signal is unpleasant sort of by design to get our attention and get us to change our behavior and move away from that source of threat. So pain represents a danger signal that changes our behavior. But the nervous system is wired such that it's always better to err on the side of caution. It's always better for survival purposes to assume that this sensation represents some type of threat. Even if it turned out that there wasn't any harm going on, or there wasn't a threat, it doesn't matter. You got away from it and you survived. And so I want you to kind of hold that idea in your mind as we go through this next section here, that our nervous system usually errs on the side of caution. It's there to protect us. It's there to keep us safe. Now, I'm not going to go so far as to say, we're going to welcome pain like it's our friend, but if you are experiencing pain, your nervous system is doing its job, which is trying to protect you, trying to keep you safe. There's a very, very rare disorder that some people are born with called congenital analgesia. And these are people that are born without the ability to feel pain. It sounds like it'd be wonderful on its face, a life with no pain, but it's actually a devastating diagnosis with a really low life expectancy, because these people will get injured, and because they don't have those pain mechanisms to tell them to pay attention to that injury and get medical attention, those injuries can become infected. They can go septic. Really scary things can happen when we don't have pain as part of the picture. So it's very unpleasant, but if you are feeling it, your nervous system is doing its job. It's just that sometimes your nervous system is an overachiever at doing that job. And that's what chronic pain really looks like. Now, in my work as a pain psychologist, we're treating chronic pain primarily, not acute pain. So this example here is talking about chronic versus acute pain. Acute pain is what you experience when you injure yourself. In this example, somebody has broken their leg while they were skiing, or maybe you touch a hot stove that was left on and you pull your hand away and you're feeling that burn. That is acute pain. And I always say that's related to a tissue issue, some kind of harm or injury going on. Chronic pain no longer is useful pain. That acute pain is helpful because it gets you to pull your hand away from that hot stove and change your behavior. But chronic pain does not serve you. All it does is get in the way of your functioning and your quality of life. And so what we want to think about is how that chronic pain develops and how we can work with it to unwind that overactivation of the nervous system that can occur in many people over time. So in that first group class, we talk all about pain neuroscience education. These are the topics we cover. And just in the interest of time, we're not going to go through the whole class here today, but I will give you just a little sample of each of the classes so you can get the gist of what we cover. But we talk about how pain is the alarm. It's not necessarily the fire. When you experience pain, it doesn't necessarily mean that there's harm going on in the tissues. It's a signal that your brain is trying to get you to pay attention to in case you need to change your behavior. Just as a quick kind of little anecdote to illustrate this, there's a pain researcher out of Australia who was doing a TED Talk and discussing kind of this phenomenon and used one of his experiences to illustrate it. So he's in Australia, so he's walking through the bush one day. And he feels a little sensation, like a little brush up against his left leg. And unbeknownst to him, that was a very venomous snake biting his leg. He ended up having to go to the hospital and he almost died. It was a really venomous snake, a really scary situation. Thankfully, he survived. And a few years later, he was walking through the bush again and he felt a little brush in that same spot on his left leg. And he immediately felt excruciating pain because his brain remembered that past experience that he had. The last time you felt something like this, when you were walking through the bush, you almost died. So his brain opened up the pain gate to create that pain experience that caused him to pay attention to that leg so that he could get medical attention and get away from that threat. Well, it turns out that it was just a piece of grass that brushed up against his leg, but his brain stored that information to protect him. And so that really kind of explains how we can experience pain even when there isn't harm going on to the tissues. Now, there's a lot that goes on in the brain when you're experiencing pain. And we enter what we call the alarm system. Some people refer to it as fight or flight. It's that stress response that gets you to react to threatening situations, again, so you can move away from that danger. So here's my kind of oversimplified explanation. Here's the no pain brain. Everything is calm and fine. Here's the acute pain brain. So let's say you've just touched that hot stove. These different areas of the brain light up in response to that. In particular, this little guy right here, it's the amygdala. It's part of your limbic system. It's an organelle embedded deep within the subcortical structures of your brain. And some people call it the lizard brain or the monkey brain. Evolutionarily speaking, it's a very old part of your brain where those survival mechanisms live. Fight, flight, freeze, and fawn, which I think I have in the slides to discuss in just a moment. But it makes sense. You touch the hot stove, you immediately need to react. pull away from that source of heat. In the process of that, what your brain does is just for a few moments, it shuts down your prefrontal cortex, which is this frontal part of your brain that's responsible for higher order cognition, organization, planning, problem solving, using logic, paying attention, metacognition, thinking about your thoughts. All of that lives up here in this frontal part of your brain, evolutionarily speaking, a newer part of your brain. That shuts down when your brain is perceiving a threat. And that's because we don't want to waste even a second overthinking how to get away from threatening situations. If I had to sit there with my hand on the hot stove, pondering whether it would be a good idea to remove my hand from the stove, pretty soon I would have a very serious burn. So we need to bypass that whole thinking part of our brain and just react, just pull away and I'll think about it later. That's really helpful in those situations, but it is not helpful when it's happening day in and day out in response to chronic pain, which is pain that doesn't necessarily represent any harm going on in the tissues. Now, what can happen over time if we don't intervene? Because, as I said, the nervous system is always going to err on the side of caution, assuming that sensation represents a threat, thrusting you into this alarm system state so that you can get away from that threat. What we start to see over time is these areas of the brain that are involved in the perception of pain, they start to take up more real estate in the brain. More and more of your brain is being devoted to sensing and processing this pain information. And this is kind of the crux of the goals of, I think, most pain psychologists, but certainly myself. Our goal, at least initially, is not to get rid of your pain. Our goal is to reduce the perception of threat that the pain presents, to close the pain gate and unwind the overactivation of the nervous system over time. Now, the downstream knock-on effect of that is that often pain decreases, but our initial goal is not to get rid of pain, it's to reduce that perception of threat, thinking about the pain in different ways, responding to it in new ways, and training your body to get back into rest and digest, which is the opposite of fight or flight, is going to help in that endeavor. So that's kind of what we work with as pain psychologists. Now, I think everybody has probably heard of fight or flight. Fight, of course, being the anger, aggression response, feeling frustrated. Flight, running away from the threat. If you can't fight it or run away, sometimes freeze will kick online. This is that deer in the headlights feeling. Like, have you ever just felt stuck, overwhelmed, like you don't know where to start? In severe cases of exposure to trauma, people will dissociate because that can be advantageous for survival. So that freeze response is one. And fawn is the least commonly discussed, but it's really relevant for folks living with chronic pain. Have you ever said yes to something when you really want to say no, but you're afraid if you say no, that people might judge you negatively, or maybe you let your boundaries get pushed a little farther than you're comfortable with because you're afraid if you push back, conflict might ensue. And as humans, we're social creatures. We depend on other people for survival. The idea of being rejected by our support group can be really threatening, especially from birth. You think about it, we're born completely helpless. So we need to be able to develop relationships with people and be really, really nice sometimes to have that support system. So it's a little bit more subtle, but I'm bringing these to your attention because a lot of what I do as a pain psychologist is working with awareness. And I always say 75% of this game is just awareness. If I can be aware that I'm in that alarm system state, specifically freeze, because I feel like a deer in the headlights, for example, and I label it, I now have agency over it. There's now something that I can do in response to it. I've observed it, so I've activated that prefrontal cortex again. Now I can make a choice about how I'm going to move forward rather than going through the passive motions. That's really important to do because there's a lot of detrimental consequences to being in this alarm system, fight or flight, stress response state. Now, everyone's been stressed here, I'm sure, at some point in time. So you probably know the physical symptoms that come along with it. Your breathing becomes faster and more shallow. Your heart starts pounding. Your blood pressure rises. Your muscles tense up. By the way, all of those things are there to bring more oxygen to your muscles, to give them more energy and stamina so that you can run away from threats. Have you ever felt butterflies in your stomach or a pit in your stomach? That's the blood very quickly moving away from your digestive tract and towards your muscles, again, to give them more blood and nutrients and oxygen. But this is why we see chronic digestive issues often accompany chronic pain and chronic stress, because digestion just keeps getting interrupted. We release a number of stress hormones when we're in this stress response state. Of course, you've probably heard of adrenaline and cortisol. Once again, these are there to bring oxygen to your muscles. But what they also do is they temporarily suppress your immune system. And that's because we don't want to waste any energy healing from injuries when the brain is still perceiving an active threat. And so over time, if this is happening chronically, we start to see dysregulation of the immune system. It's either suppressed and underperforming, which looks like poor healing from injuries, or we see an overreaction by the immune system, which looks like inflammation or autoimmune types of issues. And that certainly does not help pain. So we want the immune system functioning right in the middle in its sweet spot. So I always tell patients that this whole stress response to the pain thing is dose dependent. The lower the dose of the stress hormones, the better. It's impossible to prevent getting into this alarm system state completely because it's so hardwired into our nervous system for survival. But the quicker you can get out of it, the better. And so sometimes the act of observing it alone is enough. Sometimes you maybe want to take a deep breath or count to 10 or pet your dog or your cat or distract yourself with some music or do a stretch or lay down or use your heating pad, whatever it is. We talk about lots of different tools in the toolkit. But the point is that you're observing, I'm in this alarm system state and I can get back into rest and digest, also known as the parasympathetic nervous system response for those who want the technical term. This concept of gate control theory is a really important one for us pain psychologists to impart to our patients. And we talk about how these parts of the brain, the feeling center, which is the amygdala, we talked about, and the thought center, which is this prefrontal cortex, higher order part of our brain, are really the parts of your brain that are making that decision about that pain sensation. Does this represent a threat? Do I need to bring my attention to it and open that pain gate so I can get away from the threat and get proper medical attention? Or does this sensation not represent a threat so I can ignore it or distract from it? How the brain makes that decision is very complex. As I've alluded to already, your brain is going to access past memories, like the example of the guy walking through the bush. His brain remembered that sensation in that place meant life-threatening situation. So it opened the pain gate to get him to change his behavior and get away. And so your brain will access those old memories. Your brain will also use all of the contextual information, all of the information that is going on at the time, how you're functioning emotionally at the time, what supports you have in place, because that gives you a sense of either safety or danger. The context that the pain occurs in really matters a lot in the brain making this decision. Yes, this is a threat, or no, this is not. In order to illustrate this well, I'm going to tell you just a very short story called A Tale of Two Nails. And these are true stories of real patients that really kind of highlight how the brain makes this decision to open the pain gate and how much. A Tale of Two Nails is a story of two construction workers. The first construction worker was on a job site and he jumped off of a platform and he landed on a nail that was sticking up out of his surface. And that nail went straight through his boot. He looked down and he saw a nail sticking out of his boot. His brain made the reasonable assessment that a horrible injury had just occurred. He looked around and saw the horrified faces of his fellow construction workers. He immediately felt excruciating pain. They called an ambulance and they took him to the hospital. And he was in so much pain that they had to give him a really large dose of IV fentanyl, which you probably know is a powerful opioid medication. And then the doctors went forward with the task of cutting away his boot, only to discover that the nail had actually not punctured his foot. It had gone in between two of his toes like this. There was no injury to his foot. Yet he was having excruciating pain. How is this possible? Well, his brain used all the contextual information in that moment to ascertain that, yes, a horrible injury occurred, open that pain gate, create that sensation of pain so that we can get proper medical attention and get away from this threat, which is the nail in my foot. Was his pain real? Yes, absolutely it was. Even though there was no injury, he was still having real pain because this is the source of all pain, is our brain. Now, this second construction worker was using a nail gun, and that nail gun misfired. Unbeknownst to him, two nails shot out at the same time. But one of the nails shot out in front of him and landed across the room. He saw that. And his brain, looking at all the available information in that moment, immediately thought, oh, thank goodness, I have narrowly avoided a catastrophic accident. The nail went that away. I'm safe. He kind of felt a mild twinge of a toothache at the time, but he didn't really think anything of it. He was so relieved. He went on to live his life normally for the next 6 days. He went to work, he went to sleep. After 6 days, he told his wife, I think I'm going to go to the dentist and check out this toothache. So he went to the dentist, he got x-rays done. You can probably see where this is going. I can't see any of your faces, but usually when I tell this story to my class, everyone's faces look horrified. And the x-ray revealed that he had a nail lodged in his head. In that instance, obviously there was a catastrophic injury that happened, but his brain used all the contextual information to decide that injury had not occurred. He was safe. No need to open that pain gate and get medical attention. So these are stark examples, but they really illustrate the power of our brain and how we think about the pain, how we approach it, how we characterize it, the meaning we assign to it. All of this matters in the experience of the pain itself. I always tell patients in that first class that we want to start noticing how we think about the pain. When you experience the pain, whether it's constant, whether it goes up and down, what comes to mind? What are the narratives that go through your mind? Because in the second class, where we go over our cognitive behavioral therapy skills, we work on how those thoughts translate into a physical and emotional reaction, which then informs our behavior, which then leads to the creation of beliefs. So just as an example, you might have a thought like, this pain is never going to end. This is going to be this way for the rest of my life. To me, that sounds pretty darn threatening. The idea that this pain is never going to relent, it's permanent, and I will have it forever. Amplify that perception of threat. Now I'm in that alarm system state. That's changing what's going on from a physiological perspective. That's then informing my behavior because now I'm feeling frustrated. Maybe I'm going to lash out at people around me. And I might, over time, start to create beliefs like this pain has completely taken over my life. It controls every aspect of what I do. We don't want to have that belief. But in order to dismantle it, we have to go back to the thinking that is informing it in the first place. And we have to ask ourselves, is that perspective serving me well or not? This pain will never end. Well, the reality is I don't actually know because nobody has a crystal ball. Nobody knows what's coming in the future. But if I assume it's going to last forever, I'm suffering that pain in the present before it's even happened yet. And so working with this, really can make a big difference in one's experience with pain. So in that second class, we really dive into that. We talk about cognitive behavioral therapy skills, and most pain psychologists will use CBT because it's an evidence-based form of treatment for chronic pain, as well as a number of other issues. But it's a lot of just practical skills that you can use that help you identify helpful narratives or helpful thoughts and unhelpful thoughts. So I'm just giving you a little sample of what I do when it comes to cognitive behavioral therapy skills. Oh, there it goes. Sorry, I was back up a little bit. This ABC framework helps to illustrate how our thoughts about the pain really matter and how they affect the experience of it. So in this ABC framework, A stands for antecedent or activating event. These are just situations that occur. So the pain happens, for example, or somebody says something to you, things that you cannot directly control. And what we often do in our minds, just because we're human, is we jump straight over to column C, which stands for consequence. These are emotions that then inform our behaviors. So you might, experience something like you're stuck in traffic, let's say, on I-5. That's the antecedent. And you're feeling frustrated about that. That's the consequence. And so you'll say to yourself, as I have many times, this traffic is really making me angry. And that's because we forget that we have this intermediate step, which is how I'm thinking about this situation, how I'm characterizing it, the meaning I'm assigning to it, how I'm responding to it. The reason I'm feeling so frustrated when I'm stuck in traffic on I-5 is because I'm thinking of it as a nuisance. It's going to ruin my day. It's going to make me late. Why did they design these exits this way? I'm having a lot of self-righteous thoughts. And that's what's contributing to my frustration. And knowing that I can't magically teleport myself out of traffic, I have to go to column B and ask myself, what is another way to respond to this situation if I want to get unstuck from that frustrated state? And that's a big if. Sometimes we don't want to, and that's okay. But knowing that there's detrimental consequences, especially as it relates to pain, to being in that state of frustration, I need to change my response. So this is an example having to do with pain. So let's say you're having a pain flare because maybe your pain goes up and down. You might, in response to that, have what I would call a perfectly valid thought, which is, you wake up, you're in pain, and you say, oh no, this is going to be a bad day. And when my pain is bad like this, I can't do anything. I'm going to have to cancel everything that I had on my schedule. Now, I want to make this really clear, and I always tell my patients over and over again, anything that you think about your pain is valid because it's probably based on past experiences that you have in fact had. I would never debate the validity of somebody's thoughts. They're valid. What I do debate is whether or not they're helpful. Because even though this is a valid perspective, I would argue it amplifies the perception of threat. It's more likely to cause me to feel out of control and hopeless and focused on what I've lost because of the pain. And there I am predicting the future. This is going to be a bad day, even though I don't actually have a crystal ball and I don't know that it will be, but I'm assuming it is. I'm kind of setting the stage for that. And when I increase that perception of threat, it's going to open that pain gate further and thrust me into that alarm system state, which is not helpful. So what I always want to do with patients is land on perspectives about pain that are equally as valid as the ones before, but they're more helpful. This is just an example of what one of those could look like. Same situation, you're having pain. Instead, you say, okay, I know, I might not be able to wave a magic wand and get rid of my pain, but I know that there's some things I can do that could make it better. Let me try one of the tools in my arsenal. So right off the bat, you see the difference in language. There are some things I can do versus I can't do anything. Which one is more likely to help you feel in control and feel empowered? Obviously, the second one. When I remind myself that there's some things I can do, I am more likely to get back into that state of rest and digest. And I'm more likely to do those things because that's what I'm focusing my energy and attention on. More likely to close that pain gate. And I'm actually more likely to do something adaptive that might actually help the pain. I'm going to go grab my heating pad or my neck massager or whatever it is because I've reminded myself there are some things I can do. That statement is probably closer to the truth than I can't do anything at all. Those black and white thoughts tend to not always align with reality. And right before this talk, I had a group class with some patients, and I posed the question to them, like, what would be helpful? What would have been helpful for you to have heard early on in your pain journey that you wish you had known that you know now? And one of my patients said, she just stated it so perfectly. She was like, the fact that I have some control, because I always assumed that there was nothing that I could do about my pain or my condition. It was all up to the doctors to try to solve the problem, figure out what it is, and fix it. And I've learned that I can be empowered to do things for myself that actually help prevent these pain flares from happening. And so we actually listed that out when I was working with her one-on-one in her toolkit, a whole preventative pain plan. And when she does those things, she's less likely to enter that state of a pain flare, but she also has a plan for if she does. And she reminds herself that she has some control. And that has been everything to her because it doesn't feel as scary when you feel like you have some semblance of control. In that second class, when we go over our cognitive behavioral therapy skills, we not only talk about thoughts, but we also talk about behaviors and things that we can do to train the nervous system to wind down and to get back into that rest and digest state. This is one example of that such activity. This is the 4-7-8 breathing exercise. Now, there's a lot of different breathing exercises out there. I just happen to like this one because it's designed to lower your heart rate in a short amount of time. And when your heart rate lowers, it sends a message to your brain to start ramping up production of GABA, which is an inhibitory neurotransmitter that slows the firing of nerves down globally. And so it's actually a technique for panic attacks, but it works quite well for pain because of that GABA and slowing that nerve firing down. When you breathe in this pattern, your heart has to slow down to conserve oxygen because you're holding your breath and you're exhaling a lot longer than you're inhaling. So you inhale for a count of 4, hold your breath for a count of 7, and then exhale for a full 8 count. It doesn't matter how long that takes, it's just the ratio that we're going for. And the first time you do it, you run out of air, and that's okay. Just repeat it 3 more times, and if you can, take your pulse as you do it. Or if you have one of those fancy Fitbits or Apple Watches that takes your pulse, you can watch that. And it's kind of a little bit of a biofeedback exercise because you're doing this specific breathing exercise and you're watching or feeling your heart rate slow down. And that tells your brain, I am in control of some aspect of my body. I can do something and affect change on it. So it's all about building that sense of confidence. This is a great exercise to do just as part of a regular routine, like as you're winding down in the evening, getting ready to go to bed. That's how I personally use it. I've had patients tell me they've used it while they're waiting in their doctor's office and they're running late or they're stuck in traffic just because it's very effective at getting that heart rate down, sort of like tricking your body into a state of rest and digest, and then your brain follows. So that's a really great one to try out. In the third class, we talk all about mindfulness skills. And any pain psychologist that you see is going to preach some form of mindfulness to you, including myself. So we talk about what mindfulness is, which is essentially the practice of being present, being aware, and letting go of judgment. Noticing what's happening in the moment without judging whether it's good or bad or right or wrong. It just is when we're being mindful. This is hard to do, and that's because it requires that prefrontal cortex, that higher order thinking brain. And when you practice mindfulness, that part of the brain lights up because it's really that part of the brain that is required to do this thing about observe and let go of judgment and be aware of my thoughts. So we talk about some of the research that suggests that mindfulness is helpful for your brain and your body, especially when you practice it regularly, routinely. You're starting to train your brain to get back into that prefrontal cortex mind. We go through 4 different exercises. There's lots of different mindfulness techniques out there. I always emphasize for patients, find what resonates with you, because there's so many ways to use mindfulness. Like, you can do a classic mindfulness meditation, sitting in a quiet room, letting go of your thoughts, but you don't have to do that if that doesn't speak to you. Some people practice mindfulness by doing coloring books, or going for walks outside and listening to the birds, or doing crocheting or knitting, or listening to music. There's so many different ways to practice mindfulness. Just find what works for you so that you're more likely to stick to it regularly. Our bodies are an average of what we do to them. So doing it with regularity is going to confer benefits. And I always tell patients, my favorite mindfulness exercise is one called How to Train Your Monkey Mind, which is a great one to look up if you're kind of dipping your toes into the idea of mindfulness, because it only takes 2 seconds. And if you do 2 seconds of mindfulness a day, you've practiced mindfulness that day. And that counts in my book, as long as you do it every single day. I would much rather see somebody do 2 seconds of mindfulness a day, but every day, than, meditate for an hour, but you only do that every few months because you never have time. You're not really going to benefit from that. But it's just these little tiny baby steps done regularly make a big difference. So one of the techniques that we go over in that mindfulness class, we go through 4, but this is the last one that is the most relevant to chronic pain specifically, called Observe the Good. So the idea behind this is that the part of our body that is experiencing pain or dysfunction tends to get a lot of our awareness and attention naturally. I see a lot of patients with chronic back pain. And so, they're kind of always paying attention to that back. And as they're moving throughout their day, maybe they're guarding it. They're trying to prevent straining it or injuring it. The physical representation of that part of their back starts to take up more space in their brain over time. And if this goes on long enough, sometimes people start to develop beliefs about themselves that are not necessarily helpful. Maybe they'll say things like, I'm broken, I'm damaged, I'm a lost cause, I'm a mess, whatever kind of overarching negative judgment they've assigned to themselves. And it's not helpful to believe that about yourself, because you're not a broken person. You're a whole functioning person with pain. And so with this exercise, what we're doing is we're training the brain to notice parts of you that are functional, to sort of help dismantle that belief that you're this broken, damaged person. And so I tell patients, pick a part of your body right now that is not in pain, or is just functioning as intended. It doesn't have to be feeling good, just trucking along. It's not giving you any problems. And it can be anything. I've heard everything from my left elbow to my right ear. My hands don't hurt. My feet don't hurt. One patient said my teeth don't hurt. So we did her teeth. Another patient said everything hurts except my eyelashes. And I said, great, let's do your eyelashes. It doesn't matter what it is. But what we're doing is we're bringing our focus and awareness to that part of you just for a moment. Let's say I'm doing my eyelashes, I guess. So I'm bringing all my focus and awareness to them, and I'm picturing them in my mind's eye. All of my attention is on my eyelashes. I'm noticing what position they're in. And then I ask myself, how does this part of me help me? How does it allow me to function? What does it give to me? This is not the best example, but my eyelashes, they prevent debris from getting into my eyes. I'm really grateful for that. The point is that you're practicing gratitude for some part of your body that is functional. And that helps to break down those unhelpful beliefs. Because what we want to land on is, I'm a whole functional person with pain, but the pain does not define me. And in fact, it's the least interesting part about me. And I say repeat daily because a lot of what I do as a pain psychologist requires work on the part of the patient to actually put these things into practice on a regular basis, because these changes, they happen but they happen incrementally with routine practice. But you saw me do it just now. That's as long as it takes. You don't have to carve out all kinds of time and energy to do all these different exercises. Maybe just when you wake up in the morning and you're brushing your teeth, you do that exercise with your teeth. I mean, it doesn't, you can figure out kind of where in your routine you could fit something like that, but it's best done regularly. In the last class, we talk all about acceptance, and this is a really important component of any pain psychologist's work, is working with this concept of making peace with things that you cannot control. And when it comes to chronic pain, there is a lot that is outside of our control. There's a lot within our control, but there's a lot outside of our control. You know, whether your doctor is willing to escalate the dose of a particular medication, that's out of your control. You can't force them to do it. The fact that the pain is happening in the first place, I mean, you can't control that. It happens. You can only control your response to it. And that's really what acceptance is all about. We go through a lot of different kind of philosophical discussions, if you will, founded in Stoic philosophy, a lot of Stoicism, if you're familiar with Stoic philosophy, which is all about just accepting the things that are outside of our control and finding peace in that. And we do one exercise in particular, which comes from dialectical behavior therapy, which is just kind of an offshoot of cognitive behavioral therapy, which incorporates more acceptance and mindfulness work. It was actually developed at the University of Washington. And it's a really effective form of treatment for a variety of issues, including chronic pain. And this is just one of the exercises that comes from it. This exercise is all about eliciting awareness, the consequences of our reactions, because that's really the only thing we can control. And so I'm going to kind of walk you through this quickly using an example that I worked on with an actual patient, just to give you a sense of how it looks. So we ask, what is the reality that I'm resisting? In other words, what aspect of the chronic pain am I having a really hard time accepting? What aspect of it is really hard for me to make peace with, that I'm finding myself fighting? And so for this particular patient, what she said was, you know, the hardest part about the chronic pain is the fact that it's unpredictable. It goes up and down, ebbs and flows depending on the day. And so it's really hard for me to make plans because I never know how I'm going to feel that day. And I've made plans before and then I've had to cancel and then I look flaky. And so because I'm resisting the unpredictability, the behaviors that I engage in are to decide, I'm just going to shut myself off completely. I'm not going to make plans because why do it if I'm just going to have to potentially cancel them, is what she said. And so sure enough, slowly but surely, she started canceling things from her schedule. She wasn't reaching out to friends or family, and she found herself feeling really isolated and not doing anything that she wanted to be doing and having a really low quality of life. So that's the behaviors that she engaged in, and that's how she suffered as a result, is she felt isolated, alone, invalidated, zero quality of life, and not engaging in any kind of activity that she enjoyed. Obviously, that's not a place anybody wants to be. And so we asked, okay, what would it look like if you could accept the fact that the pain is unpredictable? If you could just make peace with that fact and move past it and start problem solving, what would you be doing instead? Instead of fighting it and shutting yourself off, what would you be doing? And what she landed on was, you know, look, the pain is unpredictable. Pretty much everything is. So why don't I make the plans, but I'll always have in my back pocket a plan B. So for example, she might make plans to have coffee with her friend somewhere outside the house. Let's say the day comes around and it's a really bad pain day because she didn't sleep well the night before, or she ran out of her medication, whatever it was. So she has a plan B already in her back pocket that she can suggest to the friend. And so she can say, could you come over to my house and we could catch up, so I can use my heating pad and my massager while we talk? Or could we do a phone call or a Zoom session or whatever instead? So she always had a backup plan. that helped her feel confident that no matter what happens, I've got a plan for it. So I don't have to worry about this uncertainty and unpredictability. I always know what I'm going to do. And so, what would be the outcomes of that? Letting go of trying to control something she couldn't control, which was the unpredictability factor. And what she learned was once she made peace with that, it opened the door to problem solving and coming up with this idea of always having a plan B. And sure enough, once she embraced that, she started resuming activities again and connecting with people and getting support and improving her quality of life. All of that helps pain because the brain is always trying to assess for threat. And if your brain perceives that you have a good support system, you have fun things to look forward to, you can function, you have some semblance of control, all of that reduces the perception of threat and closes the pain gate. So this process took quite a bit of time. I mean, it took several weeks for us to get through the exercise together, just to give you a sense of the timing. But that's kind of how that can look, and it really can make a big difference in someone's life. Once patients are done with my group classes, I always recommend that they create a pain coping skills toolkit for themselves. And they can either do this independently if they feel comfortable, or you can work with me one-on-one to do this. And most pain psychologists will do something along this line as well. I've just created this particular format that includes all of these different categories, and then we fill it in and make it as personalized to each person as possible. So you want it to be pertinent to your specific situation. For example, topical treatments like heat and ice. If you don't use those, we would take those off your toolkit. You just want to tailor it to yourself. But it essentially serves as a reference guide, a roadmap, so that you have a plan. You know what to do if you have a pain flare. You know what those preventative strategies are that you want to keep in your regular rotation. So it really helps to have that framework, that guide to go through. So all of my patients who see me go through those classes, and then if they so choose, follow up with me one-on-one to create their toolkits. And the feedback I've gotten is that it's a very helpful thing to have. Some people will have it as a PDF on their phone that they can use when they're out and about. I've had people who prefer like a printed copy. So once we're done with their toolkit, they print it out in like a book. An actual toolkit, when it's completed, is usually like 15 pages of writing. This is just like giving you an example of what each thing means. But it's often a lot of information. You know, if somebody sees a physical therapist and they have some home PT exercises, we put those in their toolkit. So everything's all in one place. It's organized. They have something to turn to. One of my patients decided that she was going to print off her toolkit and put it with her medications. She has CRPS, chronic regional pain syndrome. And when she has a pain flare and she reaches for her medication, her toolkit is right next to it. And she's made this rule for herself. She has to also grab her toolkit and try something from that toolkit. So she uses it in side by side with her medication, not as a replacement per se, but just as another form of coping and tools that she can use to navigate it. So that is everything that I have for you. What I've included in these slides, and I don't know, John, if you wanted to send them out to the attendees today, but you're welcome to. I can just email them to you. But these are the homework assignments. I don't really grade people's homework, but I recommend things to practice at home. And then some of the resources, just so you have links to the different books, websites, apps, things that can be useful to use. I just always like to include those slides so you have some of those resources. But that is everything I have for you. Just really quickly, this is the phone number for my department. And if you have any questions, follow-up questions about this talk, I'm always happy to answer those over email too. But for scheduling appointments, you just call that number and they'll know what to do. And then the insurance codes that I bill for my service are the health behavior codes. So it's psychological treatment for a medical condition. So I am actually not treating things like depression or anxiety, psychiatric issues. I'm treating chronic pain, which is a medical issue. And so these are the CPT codes that I bill. I have been doing my group classes for about 7 years, and I've never had issues with reimbursement by insurance payers, including Medicare. They've covered it, but I always say, call the number on your insurance card and just give them these codes and verify that it will be covered. But I've never run into issues with that, except with labor and industries, L&I, workman's comp, because they have kind of a different system with how they reimburse for treatment because it's related to a work injury specifically. But I've not had any issues with Medicare covering it. And if you have any questions just about cost for my program in particular, that's the number to our patient financial services.